Okay, so this is the third part of the fluoro series, and this is just a quick review of the final two major pathologies in the small bowel slash colon, and then a rapid review of some of the things that we covered in the first two lectures. So our first case here is we've got small bowel follow through that is with a zoom up over the terminal ileum. And as a point of gamesmanship, anytime they're showing you the terminal ileum, it's a Crohn's case. Like 95% of the time, especially if it's stricturing occurring at the terminal ileum. It's a Crohn's case. You don't need to look at anything else. So Crohn's disease is typically young people, although there is a second peak, which is smaller, in older people too. So just remember that it does have a dual peak. It has the skip lesion distribution, which is discontinuous. Can involve anything from the mouth all the way down to the asshole. As we mentioned before, if it involves the stomach, you have that ram's horn deformity where the antrum is scarred. Small bowel disease always involves a terminal ileum, causing stricturing. This is how it's going to be shown if they show it. This is a classic way to show it. If they've had bowel resection before, whatever is the new terminal ileum where the small bowel is attaching to large bowel, that is where the disease is going to be centered, and that's often referred to as the neoterminal ileum. The rectum or sigmoid colon tend to be spared if there is going to be sparing anywhere. It's a transmural inflammation that involves the entire all the layers of the mucosa, and because of that, it's prone to fistula formation. And remember that inflammatory bowel disease is associated with a symmetric sacroiliitis. That's that pair mnemonic. The I is for inflammatory bowel disease. So there are three main findings that could show you with barium. Like I mentioned before, the string sign at the terminal ileum is going to be the most classic. The other two are a cobblestoning appearance of the mucosa and the pseudosacculation that can occur. Now remember, we talked about pseudosacculation also in the setting of systemic sclerosis, but they're going to show you that stack of coins or hidebound appearance if they're going to go there. String sign's where it's at. You can also demonstrate this pathology on CT or MRI, MR enterography or CT enterography. And again, you're going to be looking for disease centered at the terminal ileum, thickened, inflamed looking segment of small bowel. It can be multiple segments. It's unlikely to, although it can, I don't think that they will show it as a pancolitis. I think that they'll show it with skip lesions because that's just more classic. Chronic inflammation can be demonstrated as this intramural fat deposition. You get hypertrophy of fat in the setting of chronic inflammation, and it deposited in the wall creates this halo effect. And that's so if you would see something like this, what they're getting at is chronic inflammation, which can be seen both with Crohn's or ulcerative colitis, but depending on the distribution of where it's at will lean you towards one or the other. In other words, if you see this in its terminal ileum, small bowel, then this person has a history of Crohn's. If you're seeing it more in the colon distally, then that is going to be from ulcerative colitis. Another sign that's described with CT is this comb sign, which is basically you've got, remember I said that fat proliferation occurs in a setting of chronic inflammation. So you've got areas of fat that have proliferated, and in between each like globules of fat, you've got vessels that are occurring here and here and here and here and here. So it creates this comb-like appearance of the it's around the small bowel. So something like this. On the mesenteric side, you have this comb appearance, fat infiltration with engorgement of the vasculature, and the pseudosacculation tend to occur on the opposite side. And the reason for this is because the inflammation with Crohn's tends to affect the mesenteric side more, leading to pulling in that direction, which creates that pseudosacculation or pseudodiverticula along the opposite side. This is in distinction to ulcerative colitis, which tends to involve both sides equally. Speaking of ulcerative colitis, this is a classic way to show it. We've lost our normal haustra. We've got a featureless, sort of chronically inflamed, stiff-looking or lead pipe-looking appearance to the colon. It's involving the entire colon, starting at the rectum, moving all the way back, not skipping around or sparing any areas. You've got these ulcerations, hence the name ulcerative colitis, where you've got a halo with a central area where contrast is pulling. That's the center of the ulcer. Ulcerative colitis also has a dual peak, where you've got the majority occurring in young adults, similar age distribution to Crohn's, and then a second peak later on, just like Crohn's as well. Whereas Crohn's always involves the terminal ileum, ulcerative colitis always involves the rectum. And unlike Crohn's, where you've got skipping around, ulcerative colitis is a continuous inflammation that starts at the rectum and progresses in a retrograde fashion. Lead pipe is a buzzword. This is from this chronic inflammation, just a loss of the normal features of the colon. And you can see these multiple ulcers, again, hence the name ulcerative colitis. Three big things that I would know for ulcerative colitis: the granular or sandpaper buzzword for the mucosal pattern, the presence of pseudopolyps or inflammatory polyps can make you think ulcerative colitis, and circumferential bowel wall involvement as opposed to favoring one side or the other. Ulcerative colitis affects both sides equally. There are several associations of ulcerative colitis that are highly testable. These are the three that I would know. Primary sclerosing cholangitis, this is like a step 1 association. Colon cancer, so if you were asked to choose which one, Crohn's versus ulcerative colitis, has a greater risk of colon cancer, ulcerative colitis has the greater risk. Specifically, when the inflammation progresses past the splenic flexure, then you end up having an increased risk for colon cancer. Inflammation that is like limited to the rectum or limited to the rectum and sigmoid supposedly has similar or lesser risk of cancer. You think about an increased risk of cancer with ulcerative colitis when the disease has progressed continuously past the splenic flexure. And just like Crohn's, remember that the I in the paramnemonic for sacroiliitis is inflammatory bowel, so you can have a symmetric sacroiliitis that's similar to the Ank-Spon sacroiliitis, where it's symmetric. And this is just a CT appearance also of ulcerative colitis, where you've got pancolonic thickening involving both sides. So here's just sort of a quick way to think about this with regard to thickening in the bow, primarily the colon. If you see a focal segment that's just right here at the splenic flexure, remember that's the watershed area between the SMA and the IMA, and that should make you think ischemia. If you've got inflammation that's either right here at the terminal ileum or skipping around involving the terminal ileum and other parts, that should make you think Crohn's. If you've got inflammatory thickening that's just involving the rectum or the rectum and the sigmoid, or the entire colon, that can make you think ulcerative colitis or pancolitis. So now that we're through with that part, let's do a rapid review of some buzzwords of some of the things that we mentioned in these fluoro lectures. So ribbon bow, if you remember that ribbon bow was this appearance where you've got a narrowed, thin-looking appearance of multiple loops of small bowel. And this is your graft versus host disease. The hidebound appearance was this stack of coins look that we have with scleroderma. Remember that the folds are normal in thickness. They're not actually, it's not that they're too thick, it's that there's too many of them. So if you can think about a bunch of quarters stacked on top of each other, quarter is not that thick, right? But you put a bunch of them on top of each other, it just looks like there's too many of them. There's too many of them. The string sign is the Aunt Minnie look for Crohn's. It's that scarring that involves the terminal ileum. Lead pipe was our ulcerative colitis. Remember, this is our long-standing ulcerative colitis that has resulted in a colon that's totally devoid of normal haustral markings, diffusely shortened, often narrowed colonic lumen, can have areas of narrowing, like right here. The colon is featureless and rigid, like a lead pipe. Celiac is this fold reversal. Remember that the jejunum, which is normally feathery looking, looks like the ileum, which is normally not so feathery looking, and that the ileum will look like the jejunum. They're reversed. Jejunum looks like the ileum, and the ileum looks like the jejunum. So this part here is feathery looking. The cloverleaf deformity was this Aunt Minnie that I told you is the duodenal bulb that is scarred from chronic peptic ulcer disease. It's supposed to look like a cloverleaf, and it's just from an ulcer that's scarred down. Bird's beak was our achalasia. Remember that distinguishing achalasia from pseudoachalasia, which is a mass, is done by the fact that in pseudoachalasia it will never relax, and achalasia it will eventually relax, but it's a failure, the underlying pathology is a failure of the lower esophageal sphincter to relax. Candida has this plaque-like mucosa. Remember I showed you that the inflammation of the esophagus creates fold thickening here, 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 and that basically creates tracks or like a highway for the fungus to deposit and grow. So what we end up with are these plaque-like rows of Candida, which you can, if you squint, you can make out like there's one right here. And there's several of them throughout that. It's discrete plaque-like lesions. And finally, reticular mucosa. This is a buzzword. Remember that the word reticulum means net-like. So what you've got is a net-like appearance of the mucosal pattern. Okay, so that's it. That's all I've got so far for barium stuff. And the next lecture will be a series on the chest and with a few vascular talks there at the end of that.